16, and then we'll do a quick review, and we'll be done for the day. Okay. And then I'll just make some more announcements about the next 2 weeks. Okay, so chapter 16 just goes over alterations in blood pressure, which means it just goes over the physiology, normal physiology of blood pressure, and then it goes into hypertension, okay? So most of this stuff should be familiar to you from physiology, hopefully, but if not, we'll kind of go through most of these, okay? So keep in mind that arterial, excuse me, blood pressure, as we know, is the difference between pressures of the right sides of the heart and the gradient between the systemic movement of blood, okay? So just, excuse me, left and right sides of the heart and how that gradient goes along the systemic movement of blood. Please keep in mind, and you know the difference between systolic and diastolic. I think we all know that by now. Systolic is going to be what? Contraction of the ventricles, if we're talking about the cardiac cycle, so to speak. And then diastolic is going to be what? Relaxation. Okay, so just keep that in mind. Arterial blood pressure is produced by the force of the left ventricle contraction overcoming the resistance of the aorta, which will then open the valve. So this really gives us that good systolic situation that we have. Now, please keep in mind, and I'm sure you probably remember this from physiology, cardiac output is going to be the stroke volume times the heart rate, okay? So what does this mean clinically? If you have a difference in stroke volume and if you have a difference in heart rate, that is definitely going to affect the cardiac output. So say, for example, if cardiac output is low, what do you think the body's going to do? It's going to speed up the heart rate to try to speed up or increase that cardiac output, okay, to try to reverse it. Is everybody with me with that? Okay. So this goes over preload, afterload. You guys can read that if you don't remember from physiology, you should, okay, and how that correlates with the cardiac cycle. Systolic blood pressure, we already talked about what causes systolic, what causes diastolic. SV stands for stroke volume. And keep in mind that stroke volume, as you know, it is the primary factor that influences the systolic pressure. Because stroke volume is the amount of blood that is pushed out of the heart that's going right immediately through that aorta. So keep in mind, if you remember from physiology, the amount of pressure that happens from that left ventricle pushing that blood out through the aorta, okay? It's a very high force, very high, I shouldn't say high amount of volume, but a good amount of volume of blood that's leaving. The next thing here we have is called systemic vascular resistance, okay? And this is also a major determinant of diastolic pressure. So what does that mean? That means that now when we have all of that blood pulled up in the vessel and then the vessel starts to relax, okay, or the heart starts to relax, now what is going on with the amount of blood flow, okay, or the pressure as opposed to the fact of that blood hitting up against that arterial wall, okay? So this is the resistance that we're looking for. Now, I don't test you on this, but just in case if you see this, okay, in nursing, I'm not sure if they'll make you do that calculation. They make you do it? Okay. Maybe I should start testing you on it then.
I mean, I've never seen it personally.
No, I'm just...
Way to go. Way to go.
Good one.
But in any event, it's called the mean arterial pressure. So with this, they do call it the MAP, and they give you the equation there. Okay, like I said, I don't test on it because I don't put calculations and stuff on my test, so you don't have to worry about that. But just make sure you know what it is. Okay, MAP. MAP means mean arterial blood pressure. Okay, and that is definitely some sort of calculation you will be doing in the future. Now, there are two different types of measurements of blood pressure, believe it or not. Okay, so most of the times we already know what we call the normal, or what we call indirect way, which is the blood pressure cuff. But they do have a direct way, which they can actually place a catheter in the radial artery. And it will actually then determine, and it's very accurate as you can imagine, determine the amount of pressure that's in that particular vessel. Excuse me. Why do they do this? They do this, from my understanding, in surgery and also in some critical care units, okay, to monitor the blood pressure to make sure they get an accurate read, and I guess it's instantaneous, okay, where I guess the other one is not, okay. Now, indirect measurement, this is the one that we know normally using the blood pressure cuff and the stethoscope and making sure the arm's at heart level and all the protocol measurements you use for that. Making sure you use careful technique, obviously, when taking the blood pressure. This one will give us a reading, diastolic and systolic, and we do listen for the auscultation of cortical sounds. If you don't remember what that is, remember cortical sounds is the blood that splashes up against the arterial wall, making that sound that you hear that sounds like a heartbeat, okay? So this is how you get your two different readings if you remember taking a blood pressure. Okay, so that's that. Now, there are different things that can affect blood pressure, as you know. So what are some things that you commonly know that can affect blood pressure?
Stress.
Stress, definitely. And what people don't realize, people say, oh, stress just automatically pushes the blood or makes it contract. No. What stress does, it actually affects the neural component. So stress is directly linked to the neural component to it, which means that once you get stressed out, your sympathetic nervous system kicks in, everything gets heightened, okay, so everything's just going to start to elevate. What else can cause a change in blood pressure?
Medication.
Medication, very good. Medication could fall under humoral component because sometimes it can definitely cause issues with the hormones and so forth. What else can cause issues with blood pressure? Smoking can definitely do it. What else? Diet can do it. Weight, okay. What else would you?
Blood volume.
Blood volume, okay, so blood volume, which has to do with our renal issues, okay. So if for some reason a person has renal difficulties where they're now retaining water, okay, and when they're retaining water, where now the blood volumes tend to increase, so you know from physiology, if blood volume increases, this makes the blood pressure increase, okay. So therefore that will definitely affect blood or cause blood pressure. Blood pressure, we know, also fluctuates over 24 hours in a day. We know what happens when we first wake up in the morning with blood pressure as opposed to when you go to bed at night, okay? Now, short-term regulation of blood pressure. This, again, is something that I think maybe we went over in physiology. Don't remember if we went over it or not. But in any event, we have two different types of ways that the body will regulate blood pressure. So this is what happens. Your body knows what to do to raise blood pressure. Okay, it has two compensatory mechanisms. When blood pressure is low, it knows what to do to bring it up. To bring it down is another story. Okay, but let's go over how it brings it up. Okay, so short-term regulation of blood pressure. What happens here? If blood pressure is low, it will activate the sympathetic nervous system, as I told you earlier. Okay. Sympathetic nervous system could get activated, and then it will release the neurotransmitters, okay? So we have our epinephrine, norepinephrine, which will now get everything activated. Keep in mind that it will activate also baroreceptors. Does this sound familiar?
Yeah.
Okay, so baroreceptors, you know, will therefore activate alpha receptors and beta receptors. Alpha receptors will act on the smooth muscle by contracting them, whereas the beta receptors will now act on the heart to contract the heart and now increase that blood pressure. So keep in mind we need contraction to raise blood pressure. Is everybody with me? Okay, now, to say that, we do have medication that is called beta blockers, okay, that are given to individuals that do have issues with blood pressure, okay. Now, what a beta blocker is going to do, okay, what beta blockers are going to do, they will definitely lead to the reduction of the heart rate. So they will slow down the heart rate, relax the heart, therefore relaxing the blood pressure or reducing the blood pressure. Okay, I think that's that. Okay, so this chart here goes over just in more detail about cardiac output and the heart rate, stroke volume, so you can read that at your leisure. Okay, Now, long-term blood pressure regulation. Now, this is what it's going to involve now, a few more mechanisms, or the mechanism that we know as the renin-angiotensin-aldosterone system. Okay, and I'm quite sure you've heard of that. So, this slide, don't cross it out, just read it, okay? And this is going to make sense when I show you this other chart. So, increased fluid volume increases blood volume, which therefore increases the pressure in the vessel, okay, which we all know. Which will increase the venous return, increase cardiac output, and therefore increase arterial pressure, okay? So that's just giving you a flow chart of how that works. Now, don't cross this out, just read it. Now, this is what I want to focus on, okay? So those two slides that I said don't cross out, just read it. It's just explaining what is going on here, okay? Now, this should sound familiar to you, or look familiar. Does this look familiar from physiology? No? Yes? Okay. Okay, it should look familiar. I don't know who you have for this, but it should look familiar. Okay.
We had a different instructor.
I'm sorry. I know I did have some of you for this.
Yeah, enough said. Yeah.
Yes. Okay, now, angiotensinogen converts to angiotensin 1 by the way of renin. Renin comes from what? Kidneys. Very good. The kidneys will secrete renin and start this whole process. Then angiotensin 1 will convert to angiotensin 2 by something called angiotensin converting enzyme. Okay, now once we get angiotensin 2, what will happen is it will cause vasoconstriction of the vessel, which will therefore increase blood pressure. And it will also cause a release of aldosterone. And what aldosterone is going to do, if you remember from physiology, it will now cause a sodium and water retention. Once we cause sodium and water retention, this increases blood volume, which therefore increases blood pressure. Okay? Does that sound familiar? I hope it does. Okay. So this is basic physiology of what happens when we increase blood pressure. Now, say for example, a person has I had a...
Too late.
Oh my gosh, it is too late.
Oh.
No, you're right. No, I have a simulated case study to show you with hypertension. I'll let Mrs. Felton do it with you next week.
Not the same.
Okay. Huh?
Does she work here?
Yes, she does.
She will next week.
She teaches physiology and she used to teach Patho sometimes. Okay. So, in any event, what happens now is we talked about increased blood pressure. Now, say for example a person has hypertension, okay? When a patient is hypertensive, they do have certain medications that they can take. One is the beta blockers, which I went over with you. Another medication is what is called the ACE inhibitor, okay? And I have seen this on several NCLEX books, just to let you know. ACE inhibitors, what does it do, okay, all that good stuff. So an ACE inhibitor, just so you can understand the physiology behind it, it will block the angiotensin converting enzyme from converting angiotensin 1 to angiotensin 2. So it will block the ACE, okay? An ACE inhibitor will block the ACE. So it'll stop this process. Which means when a person takes an ACE inhibitor, it won't even go this route, okay, going down there. Now, another thing that you may know that patients do take, along with sometimes their hypertensive meds, are diuretics, okay? Now, the purpose of taking a diuretic is so they can now not only retain but release this water. And when you release this water, it will now cause a decrease in blood volume, which will therefore decrease the blood pressure. Is everybody with me? Okay. So just make sure you understand this and the two things I just talked about.
Is that in the book?
It is in the book somewhere, I'm not sure.
Page 337.
Okay, thank you. Page 337. Okay. What were we saying? Okay, yeah, lifestyle changes. Yeah, we know. Okay.
Skip.
Yes.
Stop cross.
Now, hypertension. Let's get right into hypertension. Yeah, it's just talking about changes in blood pressure. We know there's different lifestyle changes. Okay, it's stuff you already know. Okay, now hypertension, we know that hypertension is a serious condition. Okay, and what happens with this, this is something that is quite common. They say responsible for annual worldwide death of a rate of 7 million. Okay, not that you have to memorize that, but
Yeah, Chris.
but just make sure that you understand. Yes, it is a definitely a increased situation. Now, a couple of things I want to go over with you. They have this committee called the Joint National Committee on Prevention and Detection of Evaluation and Treatment of High Blood Pressure. Okay. So they came up with this committee, and the purpose of this committee is that they actually changed the guidelines of hypertension. Okay. Now, when I was in school, believe it or not, it was a long time ago.
No longer than me.
Even though I don't look it, but it's, yeah. So in any event, when I was in school, they actually had a different range, okay, for blood pressure, okay, different than what they have out now. And the reason why this committee changed the range is because they wanted to catch patients that were pre-hypertensive, okay. So the pre-hypertensive stage that you'll see in the chart that I'm about to show you, it was actually normal when I went to school, and what they had in books is normal. Okay. Now, please make sure you know this chart. I will test you on this, okay? So please know this, okay? This is table 16-2. I'm not sure what page it is in your book.
334.
Page 334. Okay, so make sure that you okay, please study that. I will have questions on it. So make sure you know the normal range, okay, that they're showing you here, less than 20, okay, less than 80 for diastolic. Pre-hypertensive there, 120 to 139, and 80 to 90. And believe it or not, like I said, when I was in school, that was normal. That was considered normal when I was in school. But now they're considered as pre-hypertensive, okay, because they're just trying to catch people before. Okay, and then there's stage 1 and stage 2. Okay. Now, sometimes, as you know, patients can have a lower blood pressure, okay, and not to get confused with a systolic pressure that's below 90, because that's different, okay, but anything that is like in the hundreds, okay, that is okay, even though people get a little nervous, and sometimes depending on a person's size and if they're petite, okay, that's normal for their body type. That's okay for them to have a lower blood pressure like that. But in any event, this is the classification that they use. Okay. I'm not holding you responsible for that, so you can cross that out. That's just going over the percentile.
So good.
Okay, now, the rest of this, hypertension, we have primary, okay? And with primary hypertension, this is the most common form. Please make sure you know that. It is idiopathic disorder, so they're not sure exactly what causes it, although yes, we know there's tons of risk factors, okay, that causes hypertension. Now, they do have different subtypes. Sometimes people can have a systolic hypertension or a diastolic, or they can have both. But the most common form, just to let you know, is the systolic, okay? But sometimes people can have a diastolic. Risk factors that are non-modifiable, okay, which I think is one of those questions that the lady showed you earlier, okay? Family history, age, you can't change your family, okay, although we would like to. So family history, age, okay, you can't change that. Also sex, okay, that's not included there, but men tend to be more at risk than women, although they are finding,
Of course.
yeah, but although they are finding that females are now almost, equal to the men with this situation.
Just kidding.
With hypertension. And Also, they say African American males are more at risk as well. So African American males and age, I think the age is, don't quote me, I think I want to say 50, around that age, and then family history. Now, things that are modifiable are going to be dietary factors, sedentary lifestyle, obviously, obesity, and if they do have any type of metabolic syndrome. So that can be changed, okay, by increasing their activity and so forth. Okay, now, no, don't cross it up. Outcomes. Make sure you know that when a patient has hypertension, people wonder, okay, well, what are the signs and symptoms of a person with hypertension? Some of this you guys may know already. So what are some signs and symptoms that you may know?
Blurred vision.
Blurred vision, headaches, very good.
Ringing in the ears.
Okay, ringing in the ear. Sometimes they can also get neuropathies if it gets that bad. So please keep in mind that there can be a lot of in-organ damage. Okay, okay, not to scare you with this. This, when you read this, this should be easy to you, easy to understand. So, in-organ damage, heart, kidney, brains, eyes. So as you said, they can get the retinal detachment, they can get blind if it gets that bad. They can get a stroke, okay? So we all know these things. Aneurysms, renal failure, okay? The heart can go into a whole bunch of issues. So this should, I'm not telling you to cross it out. I'm not, well, if you want to memorize it, go ahead and memorize it. But I will test you on this, okay?
Well.
Just make sure you understand what parts of the body are involved, okay? Now, treatment interventions, please keep in mind that although, yes, we talked about ACE inhibitors and beta blockers and diuretics and all that good stuff, but keep in mind that what's very important as well, and especially with you guys as nurses, is educating them on their lifestyle modifications. To tell them to stop eating a lot of salt, okay? Making sure that they change their diet, try to get some exercise going, okay? So there's a lot of things that can be modified along with the medication. You don't have to worry about this. Now, this is,
Which one did you say?
this one here with the colors. This you guys are going to get when you get into nurse, because they're going to show you how to treat your patients with that. So that's a whole nursing thing. Now, I do want to just quickly show you weight reduction, making sure that they get the recommended weight. DASH diet. Okay, not the Kardashian. DASH diet stands for Dietary Approaches to Stop Hypertension. That's what DASH stands for, and it's down here at the bottom. So, it's okay, just know it as the DASH diet. Okay, decrease the sodium, so making sure no more than 100 millimoles per day. Exercise plan, okay, 30 minutes a day. And actually they tell women, we actually need to exercise at least 30 minutes a day, just on a regular. So, just to let you know. Moderate intake of alcohol, okay, so less than 2 drinks a day for a man, and less than 2 drinks a day for a woman.
If you're drinking on vacation. Oh.
Okay. So, just make sure you go over
We
that.
need to know all those numbers at the side, and how much of what.
You want to say no?
No, this, no, but this, yes. The recommendations, yes.
Wait, that's what we need to know?
Yeah. I had a question last term, which I'm going to change, because it was kind of a trick question. Because I think the question was like, did the person have like 10 drinks a week or something, you know? People got so confused with that. Oh. They thought it was okay for a person that have hypertension to have 10 drinks a week.
Because moderate is.
Because it's less than two, they're averaging less than 2.
Yeah, it was a tricky. I'm not gonna. But the point I'm trying to make is make sure you know the recommendations, because I will ask a question about that. Yeah, that was the other thing too. It was like 6 ounces. Yeah, 6 ounces.
Oh my goodness.
He's gonna walk into the 40 to 20.
Not a shot glass, but a full glass. Okay. So in any event, these are some of the medications. Some of these we talked about already. So I'm just going to hold you responsible for the ones that we talked about. So just understand what diuretics do, just basic understanding of it. Understand what an ACE inhibitor does, just basic understanding of what I talked about. And I did talk about the beta blockers as well. Okay. So just again, a basic understanding of that. Okay. Secondary hypertension comes from a pre-existing condition. Okay, so that's the main thing you should understand from that. And it could be from a renal disease, sometimes pregnancy. You know, patients can have gestational hypertension, and what will happen is that it can, sometimes turn into a hypertension, possibly. So it can be related to those things. That's that. I want to. You can cross that out.
Yeah.
Thank you.
I do want you to read this because I want you to understand that sometimes if they have severe end organ damage, that it can be an emergency situation. That's basically what that's saying. Okay, so not to get all crazy about it. And then the other thing here is low blood pressure. So sometimes patients can have an extreme low blood pressure. Just to kind of give you a basic understanding, most of the times this can be seen in the elderly, especially when we talk about positional type of changes that they have that can give them a low blood pressure, what is also called orthostatic hypotension. Okay, so just read this and know exactly what it is, okay, just from these 2 slides, and that's it. Okay. And that's simple as that. So to review everything we've lectured on, there's nothing really to pinpoint, honestly. Let me just say something. Please make sure that you go over the laboratory testing, okay, that I told you to highlight, because that will be included on next week's test. Next week's test is not going to...
Say it.
I was going to say it's not going to have pictures. If it does have pictures, it's just going to be like the purpura, telangiectasia, just those 4 little things on the skin, okay? But not a whole bunch of other pictures, okay? So not many pictures. Please make sure you understand the material. Please make sure for each topic that you write your own little case study and understand the different components of it. Yes, I will have more NCLEX style questions next week. So just get prepared. Please read all your material. I will also have tutoring on Thursday from 2 to 4, and the room number has changed. It actually changed to 314, just to let you know. So I'm supposed to be in 314 for tutoring. I will try my best to get those videos up by the end of the week for next week. So keep in mind that it's business as usual. So even though I will not be here, Mrs. Felton will be here. You come in, take the test. Don't give her a hard time. Come and take the test, and then what will happen is she will sort of just kind of recap, okay, some of the chapters for you, although you guys will have the videos already. Okay, and then you guys will do a lot of in-class assignments, a lot of different projects and things that she's going to work on with you. And I will have her do that simulated case study with you because it's really cool. And it kind of gives you that ATI feel.
So for 2 weeks?
Do we have